It's pretty much afternoon, and I hope you all had lunch. I think it's a mixture of people that we have, right? We have few doctors, and I don't know the background. Can you please tell me your background? Counselors? Do we have counselors, psychologists, social workers? A few responses in the chat box would be nice. So I would like to have a very interactive session. I might be asking here and there questions, so I hope you'll be fine. Yes, thank you, Fabi. Right, thank you, Akansha. So thank you. So today we are covering communications. That's part one, where we'll be mostly looking upon the basics of communications. This is a very simple topic, so most of the things you might be aware of already. But let's, I guess it will be at least a refreshing session for you. You might be refreshing the points at least. Okay. Thank you. So I have a few responses again. Thank you, technical project manager, counselor. Thank you. Thank you so much. So why do you think that this module is included in this course? Any ideas? If you can unmute and say it's well and good, and if you can use the chat box, that will also work. So partly, most it is said that most of the studies show that most of the medical errors happen due to miscommunications. That is, we could avoid most of the medical errors that happen if we had a proper communications. If we had a proper communication, it's not just between the professional profession. It might be a doctor, psychologist, nurse, whoever is having a conversation with the patient, but also amongst the team members. So it's not just the communication that happens between a counselor and a patient, a client, or a doctor and a patient, but even within the teammates, the team that we have. So all the medical errors, somehow at least 60 to 70% of the medical errors occurs due to poor communication, right? So which is completely preventable if we know how to go about having communication, right? So if we take communication, most of the time leads to better diagnostic accuracy, patient compliance. So what happened here is that, so we had a patient, okay? So she was having cancer. She had a mother who passed away due to cancer, and she had an aunt who was taking. So it was mostly genetic. So she had an aunt who was having what do you say? Who was suffering from cancer and who was taking treatment, right? So just a second, I'll switch on the video. Right. So who was taking treatment for cancer and she was actually showing a better result. So when she herself got the illness, she was in a dilemma. She didn't know like whether to take the treatment, and she was in this idea that okay, my mother anyway took the treatment and it did not progress well, and it kind of deteriorated her the disease continuation condition, kind of the prognosis was like very poor. So why should I be taking this treatment? So we had to like sit with her, make her understand like the stage that she is in is like, where we could, this could be like at least the malignancy could be preventable, and at least we could hold her, at least the treatment will be more feasible for her. It's not just like her mother's condition that is going to be. So this conversation is not just between a psychologist and the patient, or a counselor and a patient, and the whole team will be there. So the doctor will be saying his part, the medical part, the doctor will be convincing her now why it is important to take the treatment, why it is important to take all the medications as per the rules, and why it is important for her to be adhering to the treatment. So after a while, after a few sessions, she was convinced that okay, I'll take this treatment because she felt okay, my condition is different from that of my mother. So maybe I might have a better prognosis. So I'll adhere to the treatment. So patient compliance also increases by having effective communication. It's not just that we are a prescription medicine, the doctors are the prescription medicine where we just prescribe some medicines and leave off the patient like that without even explaining why this treatment is important, why it is important to take this treatment at this point and not in a later point where the disease condition is much worse. So it increases the diagnosis accuracy, patient compliance, patient satisfaction. For example, the feel that the patient is being heard, the feel that the patient gets, okay, at least there is someone to listen to me, gives a greater satisfaction. And obviously, the communication, if we have a proper communication within the team satisfaction will also increase. It's not like that, the doctor is in a higher authority and say, okay, I won't disclose this information to the psychologist or a social worker. So everybody has to be on the same page if we are like looking upon a better treatment for our patient. So the team satisfaction also increases by having proper effective communication. Patient safety and chances of litigations. We can decrease the disagreements that happen usually between a doctor or a counselor or a social officer or a nurse and a patient. So this is why communication is important. So what is active listening? This is like a very common topic, right? We have been hearing about active listening for a long time. Active listening and hearing, the differences between hearing and active listening. So what is the difference between, what is active listening? One or two could unmute. If it's not possible, I understand it won't be possible at all times. So you can use a chat box also, right? What is active listening? So I have about 24 participants. Okay. One will be myself. So I have 23 participants. Okay. Among this 23 participants, I might have one or two active listeners, and all the others will be hearing, right? So they might be sitting there passively hearing what I'm saying and not processing the information that I'm telling here. So that is a basic difference between hearing and active listening. So in active listening, what we do is, yes, thank you, Kiran Saha. Those who pay attention to another person, right? In active listening, what happens is that we actively process the information. Thank you, Miral. Listening for meaning, also using body language, right? So here, what we do is that we process the information that is being said to us, right? Here we process the information that is, it's not just idly sitting and listening to what the other person is saying. It's conceptualizing, comprehending what the other person is saying, and aligning the information, the new information with the already existing information that we have, right? So this is active listening. And active listening is one of the crucial point of communication. Right. So what are we covering today? I have divided the section into two: some positive body language for active listening and some helpful verbal do's and don'ts in active listening. So these are the topics that we'll be covering mainly. Is my pace okay? Is it okay? Thank you, Sarita. Thank you. Thank you, Dhavni. I can see a few non-verbal communications, right? Dhwani, it's Dhwani, right? Sorry, right. It helps me also to respond. Okay, the non-verbal cues that happen here, right? So, what does the baby's photo gives off? What messages? What does it convey? Any inputs? What kind of information that we get from this boy, a baby? Look, just merely by looking at her body language, her facial expression, she looks skeptical, bored, right? Anything else? Disinterest. Thank you, Parag. Bored, Viral, Dhwani. Anything else? So, see, the baby is not even saying anything, okay? The baby is not saying anything, is not even lazy. Thank you, Kiran. The baby is not even saying anything, no words. We cannot listen to anything or any no active words or anything is there. Doesn't want to respond to. The baby looks fed up. Oh my God, oh, what all these things happening, right? Already fed up with life at age 4 might be, right? Yeah. So that is where the body language plays the crucial role of body language. So body language, are we aware? See, it might be as simple as my hand movements. Okay, the hand movements could give a lot of messages to the person who is sitting in front of you. It's not just the patient, whoever is sitting in front of you. the way I move my hand, the way I look, the way my body is placed, the way I carry myself. So all this gives off some message to the person who is sitting right in front. See, for example, if I'm taking this session lying back, having a relaxed body language, even you won't be interested to listen to me, right? So the whole body language plays a very important role in communication. So the baby says, I can't be held responsible for what my face does when you talk, right? So even if I'm not saying anything, I am not responsible for the reactions or that comes up in the verb non-verbal cues that comes up in my face or my gestures or my body language. Right. So according to Albert Mehebian's model, only 7% accounts for the spoken words. Of the 10% of communication that we do, only 7% is accountable for the spoken words. 38% takes up with voice and tone, and 55% of the communication that we do is through body language. Just take our voice and tone. I am taking this session throughout the session, okay, for about 1 hour, 1.5 hours. I'm using a single monotonous tone throughout the session. Will you be interested in listening? No, right? So I'm just sitting here. Okay. So we are covering communication today. So the things that we cover in communication is body language, and see, even that is very boring, right? You won't be interested in listening to what I'm saying. So the voice, how we articulate, how we make the intonations, the tone that we use also plays a very important role in even if I'm going to emphasize something important, I might increase my tone. So this is like very important. Okay, so you all be like interested. Okay, so this is something that is going to be asking that is going to be asked in the assignment, so I'll just pay attention there. So the tone, the voice, the articulation, the intonation also plays a very big role. So that tone, voice takes up 30% of the communication. Even then, the higher position goes to the body language. 55% is being taken by body language. So this model is just to emphasize on how important the body language and tone is when you communicate, right? So what are some of the positive body languages? So the first and foremost is eye contact. Second is facial expression, tone of voice, body position, body posture, body space, and touch. So we will be looking each of these aspects in detail. So imagine you're sitting in your clinic, in your OP, or wherever you're having your OPD or sessions or whatever it is. A patient comes over, okay? The patient comes over, and the first and foremost thing, obviously, is the eye contact, right? Just imagine we have been in OPDs, right? We go to OP, we go to see doctors and nurses, and also what we usually see is that they would be sitting there either looking at their phone, or they might be having the file, and they might be just going through the file, right? Reading something, reading a book, reading the file of the patient or something like that. So the first and foremost thing that we have to create is the eye contact. So that is the first thing that we, the first mode of communication that happens between two strangers is eye contact, right? So a patient comes over, the first thing that I happen to have a communication, if I want to have a proper communication, is to make a eye contact with the person who is sitting in front of you. At least, it's like acknowledging that, okay, I saw you coming over, and I just acknowledge with the eye contact. So it is very important that you have a eye contact. Sorry. Right. So eye contact is very important. So even while having a conversation, it is necessary, it is mandatory that you maintain the eye contact. When I say maintain the eye contact, it's not like staring into them. You shouldn't be like stare into them and scare them off. Okay. You have to maintain a very gentle eye contact. And see, obviously, we are professionals. We might have a bad day. We might be tired. We might have seen a lot of patients. So we might feel like taking eyes off their eyes. Okay, so we might slightly feel like taking the eye contact off. So what you can do there is that if you want to look away from the eyes, make a very gentle movement and look somewhere else on the face. Okay. So there is something called as good triangle where you can look. Okay, it's not necessary that you have to look into the eyes throughout. So you can look somewhere else on the face if you want to gaze away from the eyes. right? So tips for making a very good eye contact: when you look, do it very slowly. Don't just scare them off. Don't look down when you want to look away. Don't look down on a person or a patient or whoever is sitting in front of you. Rather, looking away, look at another spot on the face. So even if you get tired of looking at the person who is sitting in front of you, or tired of looking at their eyes, maybe you can look somewhere else. Break your gaze to make a gesture or a nod. So slightly you can make a nod, you can make a gesture, you can take your eyes off, right? So, right. So this is a good triangle. So if you want to look away from the eyes, you can uh, look somewhere else, right? You can look at these points. That is the cheek area, both the cheek area and the chin area. So if you want to look away from the eyes, this is a good triangle where you can have. So you can look somewhere else on the face. Or maybe you can just take a gesture. You can just nod your head. So the first and foremost thing that the first and foremost communication that we do with another person is the eye contact. So don't just look at the file. Don't just go through the file while you are meeting a person. Make sure that you make a proper eye contact. Right. Smile. This is like very important. See, there are circumstances where we might have to avoid smiling. For example, I don't know how many of you are working in palliative setting. If you're like communicating bad news, and if the patient is in end of life, so obviously we cannot smile, right? But if this is a case where So if it's a case where you are like for the first time you are seeing a person, or you are going to do an assessment for that person, so make sure that you make an eye contact, you smile. I know we might be wearing masks if it's the nurse or doctors or counselors. If you're working in a hospital setting, you might be wearing a mask, but smile can be seen in your eyes, right? Smile can be seen in your eyes. So make sure that you smile. Also, it can be heard in your voice. So when you meet a new person, make eye contact, smile, so that it reaches the other person. It can be seen with your eyes, or it can be heard in your voice. Tone of your voice. Just imagine there is this person who is sitting in front of you, or just came. Okay, you made an eye contact, proper eye contact was made, and you smile, and you're talking. So how is your sound is going to be? It's going to be very polite. If you're having a very cranky face and if you're not smiling, obviously your tone is going to be very cranky, right? Your tone is going to be very hard, very rude, and all. So the smile itself actually sets the base for your tone. See, if I'm talking to someone smiling, so obviously my tone will be very gentle, very kind, and very pleasant. And if I'm having a very bad facial expression and I'm not even smiling, okay, like what are you up to? Why are you here? See, obviously my tone will change. The smile itself will set the base for the tone of your voice. The tone of your voice should always be very gentle, very kind, and if they have any comprehension issues and all, make sure that you're a bit slow also, so that they understand what you're saying, right? So the smile itself will set the base for your talk, but make sure that it is very gentle and all, right? Any doubt till here?
No, ma'am.
Yeah, thank you, Dr. Prayar. Even in communicating bad news, we use not to use much medical terms, right? Even when you're communicating bad news, we don't use a word breaking bad news now. It's more because of the traumatizing effect that it gives. We use communicating bad news. So even when you're communicating bad news, the eyes show, the empathy that we have will reach there. Thank you, Dr. Payal, for that. Right. So you might be seeing patients in OP, you might be seeing patients in wards. So I don't know how this the population is, but right. So how is the first picture different from the second picture? Thank you, Shanmukha Priya. I'll be coming to that question. Okay. Right. So can you point out a few differences between the first picture and the second picture? Any differences? First is more open to communication. Okay. Standing versus seated. Thank you, Dhwani. Second is more distant. Okay.
Ma'am, I
Second,
think as per the need of the patient, they have, changed their positions. Like the first one, he's in a more sleeping position, so the doctor is trying to stand and communicate well. While in the second one, he has his wife or fiance with him, so he has to communicate with her and the patient. So that's how they've changed the seating arrangement. And in the third one, the doctor is actually trying to meet the level of the child so that they can actually build a good bond, a trust, and then they can, only when you build that trust, can you actually communicate with things. So yeah.
Thank you so much, Sakshi. But when you look at the patients from the patient's perspective, do you think who is like more relaxed?
The third one, last one.
The third one, right? The third one or the second one? The third one is a pediatric case that we have just put to for a reference. In the first picture, if you look clearly, if you look closely, you can see that the patient is straining a bit. The head has like come, or he's trying to bend, and there is this bend over his spine, and he's straining a bit, and the eye contact, the leveling is not correct, right? Here the doctor gives off an authoritative feel, right? Someone of more power, or this counselor, whoever is sitting, whoever is looking at the patient, I am of someone, some higher power authority, and also the eye contact. The patient has to strain a lot there, right? Bending forward. What if the patient is having some discomfort because of that, right? So what we usually suggest is, if you're standing and talking to a patient, for example, that usually happens in ward, we suggest you to stand at the foot end of the hospital bed, right? So what happens if you're standing at the foot end? The patient will be relaxed. The patient's eye contact will be at the same level, right? The patient won't have to strain much on himself or herself, right? What we suggest is to sit beside the patient so that there the equality, the body leveling is same, the eye contact is same at the same level, and this leads to a much greater satisfaction amongst the patient. They feel that warmth in them. Okay, the patient does not have to strain much. The patient won't feel like, won't have to strain by even looking, even strain at his neck level or something like that. The eye contact will be also be correct, right? So what we usually suggest is that, if possible, sit beside the patient and have a conversation. If at all there is no space for you people to sit, maybe if you can only have a conversation by standing, then you have to stand at the foot end. I know it might be a bit far. If the patient is speaking very slowly and all, it might be difficult. We might have to go near the patient. But for a patient to be more relaxed, to be in a more relaxed position, it suggested that you have to stand at the foot end of the patient, so that the patient will have a very comfortable posture to have a conversation. What we usually see with a pediatric is that we usually bend down to the kids and talk, right? We bend down and talk, right? We bend down to the child's level and we have a conversation. So this also is not advisable, but is what we have been following for a very long time. So what we usually suggest is that, again, you can have a chair, pull a chair and sit beside the child, so that the child and you are at the same level. If that's not possible, you have to bend and on your knees, bend at the knee level, so that you are in level with the child. I don't know to what extent this might be possible in your OPDs and all, but at least having a chair, sitting beside the child, having the same level of the child will, make them more comfortable to have a conversation with, right? And coming to the body language when it comes to telehealth communication, telehealth itself has a lot of limitations, right? Seeing a person, having a conversation with the person in person is different than when you have a conversation through a telephone, right? So at least the tone can be modified, so the person on the other end will feel that the person is being heard to, right? The tone, even if you want to laugh slightly, it can be heard. And if possible, at today's age, video call, everything is possible. So if it's okay, if it's possible from your end, then I would suggest to have a video call session. So because we do have video call sessions, at least to know regarding the wound or any other thing, any other physical conditions that our patients have. And even for some of the tele counseling, we do have video call sessions if it's possible. But I do understand that all the patients may not be in a position to have a video call or a WhatsApp video call or something like that. So at least make sure that your tone is in accordance, very empathetic. The tone, the empathy that you have will be heard there, right? Okay. So the next is body posture. Body posture is another important fact that we have to keep in mind. So a patient is sitting in front of you. You cannot just lie down. You cannot just have a very leisurely body language, right? It gives off a very bad image. The patient feels like, okay, see, I shouldn't have even come here. He's not even paying attention, right? The body posture should always, if you have you should always bend forward. This bending is always going to give a very positive impact on the person who is sitting in front of you. So bend forward. The body posture is showing that you're willing to listen. So it leads to higher satisfaction amongst the patient. So you can slightly just bend forward. So it actually shows that okay, you are interested in what the patient has to say, whatever the person in front of you has to say. See, I'm showing my willingness, my interest in what the other person has to share by bending forward. See, if I'm having a very relaxed, even if I'm taking this session very relaxed, having a leg over this table or a leg over my leg, and checking my phone, reading something. See, this would give a very negative idea, or negative conveys a very negative message to the person who is sitting in front of you, right? So having a bending forward posture will always no issues, Dr. Pyle. Right. So having a bending forward gives off the message that, okay, you are interested in what I have to say. So the doctor is interested in what I have to say. So I will just share a little more. So this gives off a very positive image. The next is leaning forward, similar to bending forward. Okay. So leaning forward is sometimes a patient might also lean forward. So there is something called as mirroring. You have to mirror what the patient is showing, right? The mirroring the body posture of the patient or the person who is sitting in front of you. This also gives off the message. It's more psychological. They feel like we become more likable to them. So mirroring the body language is also important. So if they are taking a step back, maybe we can also take a step back. If they are leaning forward, if they are bending and speaking, then we can also bend. Again, we shouldn't be taking a very leisurely, lazy body posture. Make sure that the bending is always good. And sometimes it is good to mirror the body posture of whoever is sitting in front of you. This is an ideal way of showing they feel like we become more likable to them, right? Right. So another factor that we have to take into consideration is respecting body space. Okay. So when it comes to body space, we have 4 levels of body space. Intimate space, where we allow only very close friends, Mostly it could be our mother, our parents. It could be our parents. It could be our siblings. It could be our spouse. So we allow only very, very close, very intimate people into that intimate space. Then we have our personal space, where we allow a little more of our circle. It could be our friends. It could be other family members, relatives, and all. And then we have a social space where we allow our colleagues to be in, and maybe other, if you are attending mostly our colleagues and other people. There might be strangers, there might be people you might know as well. So it's a mixture of people, but it's a social place. We are like, okay. And then we have the public space. For example, if you're standing at a railway station, if you're standing at a bus stand, that space is called as a public space, where most of the people that are around you would be strangers to you. So what happens with our professionals? We are all working in we might be working with other people, right? For example, you might have patients, you might be working in a hospital, you might be having clients in your OPDs. So you might be working in different settings. There is always implied consent from the patient side, right? They are themselves coming to you, right? So there is something called as implied consent. They have some issue and they are coming to you. That implied consent is there. But that does not mean that we can go and intervene in their intimate space, right? For example, I don't know if we have any nurses in this course or any doctors are there, right? So even if you're like putting a step, it's like, thank you, Kiran. Even if it's just the step that you're putting on a person's body, see, that's going to be their intimate space, right? We know for a fact that they have come there to have some checkup. Okay, that is there. So the implied consent is there. That does not mean that we can go and just do something, we can just go and intervene in their intimate space. Make sure that you take their consent. For example, even this title actually was can be used for both doctors and nurses, right? So I might say a few cases for might relate to things that they might also do. For example, if there is catheter change, for example, if there is any Riles tube change, what we usually do, we just remove the catheter, we insert the new catheter, we just remove the Riles tube, we insert the Riles tube. We never take their consent, right? So that is invading their personal space. See, inserting a catheter or removing a catheter is we are going into their intimate space, right? It's not something that they would do if they were in a more capable position, right? So even if it's a nurse who is going to insert a catheter, make sure that you just inform them. Say, I'm going to insert this catheter. I know it is going to be a bit discomfort for you, but I'm just letting that person know that I'm going to do this. It's like taking that consent, right? Even if it's as simple as putting a step, make sure that shall I, there's this body language that will show that, we are taking their consent, right? So make sure that you always take consent before going or doing invading their personal space. Even if the patient is a stroke patient, even if he is not in a place where he can comprehend, or they might be comprehending, they may not be verbally saying anything back because they are not able to say something back. Even then, make sure that you do your part, right? See, I'm going to insert this catheter, or I'm going to remove this. I'm going to insert Riles tube. And this is going to be a bit discomfort for you. This is going to have a little bit discomfort for you. Even if the patient cannot respond back, make sure that you at least take the consent. At least you do your part, right? So patients, they shouldn't feel that we are invading their space. Can you look at the two pictures and I think the picture is very self explanatory, right? What's the difference between the first two pictures? How is the patient in the wheelchair? From what can we make out of the patient's facial, the body language?
The patient is scared.
Thank you so much. Thank you so much, Sima. The patient is scared. It's not comfortable, right? Right. I can hear a few voices here and there.
The healthcare professional is entirely in the personal space of the patient and is also not at the same level.
Right.
So the patient might be a little intimidated.
Right. Thank you so much.
The second picture,
Right.
the person is sitting next to the patient. They are at the same height level. There's a good amount of distance, even though they're sitting next to each other. There's a distance wherein, if there's any kind of a pat on the back or anything, that would also be possible, but it's a safe distance.
Right. Thank you so much, Kaize. I hope the pronunciation is correct. Right. So, yeah. See, the first picture has, all of you have mentioned, the patient is not comfortable. The doctor is in a hurry. The doctor is standing. The doctor is posing as someone of more authority. The patient is feels threatened, scared, feels like somebody is invading my personal space. Right? As compared to the second picture, the patient is very comfortable having the space, the eye contact, there is mutual respect, empathy is obvious. Thank you so much, Dr. Pal. And the patient is more at comfort. The patient feels more at the same level of who the professional is sitting in front of the patient, right? So this is why we recommend sitting, the body leveling, the eye contact, the smile, the space. We have to respect all these things, right? And the last part of the body language is touch. Thank you, Dr. Payal. So here in the section, that's a very good point that you have noted here. the patient might actually feel like sharing a little more, communicating more here, because there is this open space there. So that is also one good thing. Touch is very therapeutic. I don't know how many of you might have actually felt this in your counseling sessions or in your personal sessions. Touch is very therapeutic, and the COVID has everything has made us more what do you say apprehensive of having a touch with whoever is sitting in front of us, of the patient that we talk to. But it has like come down like anything after COVID. But I highly recommend. It's not a very in a way that it invades their privacy, invades their space. Make sure that you have that comfortable space with them. At least a hand, holding their hand, or patting on their shoulders will do wonders. For example, if I'm having a conversation, with a person and I'm communicating bad news, and the patient, whoever is sitting in front of me, might be at the brim of crying. Okay? So they won't cry. They might be holding all those up, holding all those emotions up. And if I just gently touch their hand, they'll start breaking down in front of me. That's the magic of having a touch. So use it wisely, and whenever it is necessary, and whenever you feel it might be appropriate and accurate, and it has to be a very gentle, as a gentle hand, holding their hand or holding their shoulder, a gentle pat it could be. So it completely makes them what they will just break down all the barriers that they have built around them, and they will cry like anything with a single touch. So touch is very therapeutic and very empathetic. I'll just Yes, Dhwani.
I understand about the therapeutic nature of
Right.
touch, but I just wanted to ask, are there instances in which someone might not be comfortable with that touch? There may be people who, and how do we know that? How do we find out? Are we always supposed to ask, is it okay if I pat you or hug you? Or I just wanted your
Right.
inputs
Right,
on that.
Dhwani. So, touch. So, obviously, we might need a little rapport before we have this touch, right? We cannot just go and touch the first person, in the first OPD itself, or maybe in the an assessment phase itself. Maybe it might be necessary also. For example, if you have seen the patient for the first time and you have to break the bad news or communicate the bad news, then obviously you might have to touch. There might be instances where you might have to use the therapeutic effect of touch. So it depends on how guarded the person is in front of you. Like if they feel like you are invading, it would be known through the communication or the conversation that you might have, like whether the patient will be receptive of a touch. I think it might give off from their body language. Exactly, Dr. Pai. It might give off from their body language itself. If they are more comfortable, they might open up a lot, and you know that okay, you have completed the first phase, and they are opening up. They might start crying, or the eyes might well up. So you know that okay, they are comfortable with you. Okay, a single touch might be okay. So you can just gently hold their hands first. It's not just a tight hug that we are giving in the first phase itself, right? You won't just go and hug them tightly enough. A gentle hand, even if the patient is in ward and lying on a bed, a gently holding their hand will also do wonders. So you know that where it has to be our intuitions also at that time. It depends on the scenario, the situation that you are in, and obviously there are certain patients, even children don't. Not all children like being touched and all. They also feel threatened and all. And specifically, if the child is having autism or neurodevelopment disorder, other neurodevelopment disorders, and they won't like touching and all. So you might have to take all these things into account before doing that. Also depends on the health of the patient of that particular day, right? So, for example, even if it's children, they might feel like okay, they might feel irritated and also make sure that you know the rhythm. You have a conversation before you go and touch. So that will actually set the pace, I think, right? I'll just go through the chat box if there's anything, right? And see, there might be also chance that the patient is having any contagious disease. So it is okay to wash your hands after touching the patient. It is also okay to sanitize yourself. Even if it's in front of the patient, it is fine. Because they will understand that we are professionals and we have to see other patients as well. So it is completely fine. Even if you are like sanitizing in front of you, make sure that you sanitize your hands, or use a hand wash your hands, and that is also perfectly fine. But make use of this touch, because it is very therapeutic, and it goes a very long way in having communications. Any other doubts? So we have like come to the end of the first session. Any doubts in these area? So we looked upon some of the body language. That is, we start off with eye contact. Then we have our facial expressions, tone of voice, body position, the body posture. We have to always have a bending posture, and there is something called as mirroring. And then we have body space, right? And touch. Touch is another important thing. Any doubts from these area, or any conversations that you would like to have, or share any experience from your case? Thank you. A few responses in the chat box would do good. That's my nonverbal communication. Yes, Kaizen.
So I also feel with touch, it is really important to know where is like a safe zone. So usually when we do the touch, it would be on the shoulder or maybe on the knee, or somewhere that is not too invasive as well, because sometimes, most of the times, when we are also working with other genders, and we are like, for example, if I'm a female and I'm doing a counseling session with a male, might not be instantly comfortable if I hold a hand or something like that. But a little tap on the shoulder or on the knee, or on the leg, if if it's a small space and you're sitting down, sometimes is also really helpful as compared to other areas. I
Definitely.
just
Thank
wanted
you so
to,
much for your
yeah.
inputs, Kaizi. One thing that you have brought up is gender. That is a huge thing. Most of the time, as males, they won't be more comfortable in having a touch with the female. If you are having a
Yes.
female patient, you won't be very comfortable with. So make sure that you have that rapport with that the person who is sitting in front of you. Even it's vice versa. We might not feel like very comfortable with having to touch a person of opposite gender. So, but nicely holding their hand, or a gradual, a very not intimidating a way of showing care, or that, as Kaizen had put, a pat on the shoulder, on the knees, wouldn't matter much. But make sure that the scenario, the situation, everything is aligned properly. Right. Thank you so much. So I'll just move on to the next session. That is verbal do's and don'ts while you are having a conversation with a patient, right? So all these are from a medical perspective, okay? So all these, it's not a counseling way of having a conversation from a medical perspective. Like if you are a doctor or professional doctor or a nurse or someone else, having to make a communication, having to do an assessment, right? So never ever ask leading questions. For example, if you're a doctor or a nurse, and maybe you're a counselor and you're going on rounds, okay? You might have seen this patient yesterday and you are going to see this patient again. Don't just ask, your breathlessness is better now, right? See, what if the breathlessness is not okay? What if the patient had breathlessness yesterday and you prescribed a few medicine, okay? Just imagine that scenario, and you assume that the patient might be better. What if the patient is not better? What if the breathlessness has not come down? When you ask a leading question, this is better, right? So the patient will feel compliant to say yes. The patient will feel like, oh, wait, see, I might have to say yes. They are expecting and yes as an answer. So I might have to say yes. So never ever ask leading questions, right? Like your breathlessness is better now, right? So your sleep is better, right? Never ask leading questions. Always ask an open-ended questions like, how are you today? How are you feeling today? See, This will open up to a greater information from the patient. We'll get to know a lot. See, if the patient breathlessness has not come down, the patient will start, my symptoms has not come down. It has actually aggravated and not lessened, and all. The patient will start saying, I had a very disturbed sleep yesterday because of this. The patient will start saying a story. So always ask an open-ended question so that you get more information into what they have to say. Never ask leading questions or close-ended questions. Don't minimize, don't compare your patient's problem. For example, there is a patient right in front of you who has come to you with a toothache. Okay. So I might be a palliative physician, I might be a counselor, I might be a psychologist with palliative care, or I might be a nurse who is working in palliative care. I cannot just say that, see, I have seen stage 4 of cancer, stage 5 of cancer, and I have seen so much pain, and you are just making so much fuss of this toothache. I have seen so much. You can never say anything like that. For them, their toothache or their headache is of their biggest trouble. So we should never minimize their problems. We should never compare. See, when I was when I had the similar situation, I did this, I did that, or maybe my aunt did this. My aunt was in a much better position. She was able to much cope with this. And why are you making a big fuss of this? It's just a toothache, or just never ever minimize, never ever compare patients' problems. Okay. Don't get so worried over small problems. See, for the person who is sitting in front of you, that small problem is the biggest issue at this point. So we can never minimize that issue, right? We can never even say that. There are so many people who are facing much bigger problems, and you are just, making a big fuss out of the small problem. You should never say that. Never compare. They will feel you don't care. The next time they are having a discomfort, they won't even feel like talking to you, because they already know what you are going to say. Okay, anyway, she is going to say this is like a simple problem. I won't even talk to her regarding this patient. I'll just say that I'm comfortable, right? Acknowledge, normalize patient's emotional experience. Anybody in your position would perhaps feel this way. If I cannot even imagine the pain that you're going through. And if the patient is saying, okay, I had sleeplessness yesterday, I might say that, okay, it must have been very difficult, not able to sleep, right? Say, I'm acknowledging what the patient has to say. So always acknowledge. You have to say, we will give you a painkiller to reduce the pain. Don't worry. Even Dr. Payal, I wouldn't just suggest, we are not, we shouldn't just suggest medicine of like that. What if there is another cause for their pain? So you need to inquire, explore into what the patient is saying. What if I was not able to sleep? It could be pain. It could be something related to I was worried about my child who was there at home, who's alone at home, and who's there. There is nobody to look after the child. What if that is what is bothering me, and that is coming out of pain? If I'm asking, like, do you have pain? I don't know if you mentioned that, or am I reading it in a wrong way? This happens with the nonverbal communication. Okay, so I might ask for clarifications in between. You should never say don't worry. You should never say, you shouldn't immediately prescribe medicine. At least explore what the condition is, what the pain is, and obviously we need to symptomatic management has to be done, but find the cause also. Get to know what the person is worried about, if it's worry or if it's pain. And if it's physical, obviously pain management, symptomatic management is the first thing that will be coming up. But again, ask for other concerns that the patient might be having. Explore. That is the most important thing. So the next one is, don't minimize, don't compare, acknowledge the patient's feelings. Don't give false hope. We cannot say that, okay, see, everything is going to be all right. Our hospital is of great name. They will take care of everything. We should never, ever give false hope. And even if it's a patient who is a paraplegic a paraplegic patient that you're seeing, that is both the limbs, they cannot walk and they are wheelchair bound, we cannot give them false hope that, okay, you will walk someday. Never, ever give false hope. Whatever communication you are doing with the patient, it has to be very honest. And if it's a bad news, how to communicate bad news will be taken in the next session. So do not worry about that. But never give false hope. You cannot say that, I'll take care of everything. The team is very good. The team will take care of everything. We can never assure that. Okay. Do give realistic hope. See, your disease conditions might be progressive, but let me see what I'll be able to. Let me see to make you more comfortable. I'll do from my end to make you more comfortable. I cannot make, see, we cannot give assurance that cancer is going to be cured or the pain is going to be completely gone or anything like that. No amount of false hope can be given. So whatever you're saying, it has to be honest, factual information. And never assume. How use your breathlessness? We cannot assume that their breathlessness is much better. Always inquire with the patient to what extent they are feeling today. Right? Right. So the third portion is history taking. Anything in this area, right, like the verbal do's and don'ts, never give false hope, don't compare, don't minimize, and don't ask leading questions. These are the major things that you have to keep in mind when you are having a conversation with the patient. Anything else that you would like to add, or anything else that you have queries or any doubts from your clinical experiences that you would like to share? Anything? Okay. I'll just give another example. Okay. Grief was taken for you. Grief and bereavement topic is on. Thank you, Parag. I could see your body language. Right. So in grief also, it might be taken. There is something called as we shouldn't give. Even when someone very close to us has passed away. Okay, maybe a friend of ours, or it could be someone who has passed away. There is this natural tendency for us to say, just call me if you need anything. I'll be there. Never give that hope also. You have to be very specific on giving you have to be specific on what things you might be able to help. Maybe I'll be able to drop you at school or drop you at your workspace. It has to be very specific. You shouldn't say that, I'll take care of everything. Just call me up. Will you be available 24/7? If you say that, okay, just call me up whenever you need something. No, we cannot even give that hope to that person. Okay, just mention, okay, I'll be available if you need anything. I will be available from 9 to 5. If it's a patient, obviously it has to be more professional, right? So I will be available from 9 to 5. So if you have any queries related to a disease condition, if you have any other doubts, you can ring me up in this number. I'll be available from 9 to 5. That boundary is also very important, right? Don't be dismissive. Thank you. So we'll go to the third section of this communication part, history taking. So this is basically for anybody, the nurse, doctor, or the counselor who are having a history taking, the assessment part. Okay. So how to go about the history taking? So a patient is coming to your OPD, and so the first thing that we'll do is we'll make eye contact. We'll make sure that whatever we are doing, we might be checking their file, we might be going through blood samples results, or whatever it is, we'll just gaze, we'll make a proper eye contact, we smile, and we nod our head. This is the first thing that we'll do when a patient is coming to your OPD. And say, good morning, namaste, namaskaram, whatever is in your regional language, you say that, right? And offer them a seat and make them more comfortable there. Make them comfortable. Offer a seat and ask them to sit beside you. Sit beside by the bedside. If it's in IP or if it's IP ward rounds and all, just make sure that you just wish them, make eye contact, smile, wish, and you sit beside the patient. Start the interview with an open-ended question. So, how may I help you? What brings you here today? If it's an OPD, and if it's IP, how are you feeling today? How are you today? Okay. So if it's an OPD and you're seeing the person for the first time, it could be more like, how may I help you? Or what brings you here today? And if you are seeing the patient in the ward, it would be more like, how are you today? Okay, these are the open-ended questions which will help us explore more into the patient's condition, present condition. Listen, do not interrupt. See, I do understand if in a normal hospital, it's not, if it's not a palliative hospital and there are like all the OPDs are there, we won't have so much time with every patient, right? We might have to rush through conversation also, but it is okay. If it's that rushy OPD, I do understand the limitations, but what we prefer is listen to them. Obviously, the patient might derail off. The patient might start saying, I went to this marriage yesterday, my sister's my nephew's marriage yesterday, and I had an ice cream there. And from that moment, my throat started, tracking up. And from then, I had this fever. The patient might, say a lot. If you want to bring back the conversation into a point, be specific. Okay, what actually is the what brings you your, is it troubling you? So you always have to bring them back to track. Okay, otherwise just listen to them, listen to whatever the patient is saying. Okay, they came there and this I showed this result to the doctor. They said that there is mass in my stomach, and I from there I went here. So the patient might start saying a lot. Do not interrupt. Listen carefully. Right. Encourage the patient to talk. Maintain eye contact while you are having a conversation. And if you want to move your eye contact, make sure that you look somewhere else on the face. Nod your head from time to time. It will make them make feel that you are listening to them. Make encouraging sounds or words like acha, like ha, to, or fit, like go on. Okay, I'm here. I'm here to listen to you. Clarify as you go along. If you have any doubts, make sure that you clarify. I did not understand. Can you repeat what you said? I lost there. Can you say what that means? And all? Ask about what they understand about their situations. What did the doctor say there, tell you? So the patient who is sitting in front of you might have already seen a lot of other doctors, right? They might have come to you after a lot of consultation. If it's the doctors or the nurses, if it's a psychologist, it's not necessary that they might have already seen doctors. It might maybe our doctors might have referred, right? The clinic in your work where you work, the doctor might have referred the patient to the counselor. So the counselor will also have to ask you, what did the doctors there say? To have an idea of whether the patient has an idea of his or her disease conditions. We need to know where the patient is, right? What his understanding is about his or her disease conditions. We need to have an idea of that. So you can just casually ask, what did the doctor there say? Did he tell you something? Did she tell you something? Okay. So the patient will again start saying a lot of things. Okay, do you know what the report says? Most of the time, what happens is that we have Google today. We have all those chat GPTs to get to know our disease conditions. Everything is already, the patient might be, might have done a PhD and might have come to you already, right? Might have a lot of idea of disease conditions, maybe more than you. So you might have to have an understanding of what the patient knows right now. So for that, did you go through the report? Did you read the report? You know what the report says. You need to have an idea of what the patient is has an knows, right? So the patient might say, "Yeah, I just went through the report, and there was stage 4 cancer was mentioned in the report, and I went and googled this and saw that this is so and so, and that there is no use of taking treatment or something like that." And the patient have a conversation, explore what the patient knows, explore to a greater detail, and ask about their concerns. What are your major concerns? What is it that you fear of? What are your major concerns? Is it symptomatic management? Is it the psychological factors? Is it the spiritual factors? I mean, what are your concerns? Share information honestly. Use simple language, no jargons. Somebody has already mentioned in the chat box. No jargons, no medical jargons, no big words and all. Simple language. We might deal with emotions also. The person might break down in front of you. We might have to deal with that, make them comfortable. Discuss treatment options. See, these are the facilities that our hospital has. You might have to take up these treatments. And what if the patient doesn't want to follow allopathic treatment? And the patient feels like, I'll just go and take Ayurvedic treatment, or I want homeopathic treatment. Make sure that you say your part. See, these are the availabilities and these are the treatment options that you have. Obviously, which one to follow is their wish. They can choose anything that they want, the treatment options. We cannot just say that, you have to follow this treatment, you have to follow this regimen. This is what is mandatory for you. We cannot never force things into them. Just say these are the treatment options that you have. Just give it a thought and just let us know what you would prefer. Discuss pros and cons of options. Recommend a line of treatment. And even if there might be patient who would say, see, I won't take any medicines. I will just go to a tantric for this. I'll just do some puja for this. I'll just light candles for this. There might be patients who come up with things like that also. We cannot force them into treatment. You have to say that, see, this is your disease condition and these are the treatment options. And this is what we can do from our part. And obviously, the choice is theirs. They can follow their their line of treatment that they want. You are more than a prescription vending machine. So you are not just there to prescribe some medicines. You are there to clarify, explore their concerns, clarify, make them understand what their concerns are, and give your options to them. Listen to their beliefs, fears, problems, and constraints. Even if we give them the best suggestions, it's not necessary that they take up. Even if we give our best suggestions, the best treatment options, they might say that, okay, I'll just do some puja and I'll be fine with it. I don't want any treatment. And if they say so, we have to respect that. Always respect the patient's decisions, right? Participatory decisions by consent, family plus doctor. So the decision you also have to inform the family members regarding the important family members regarding the same. So the patient has decided, okay, they will have this treatment. We have to inform the other family members. So the decision has to be participatory. The whole team has to be there. Along with that, the patient and the family members has to be there. And then summarize the interview. So confirm the treatment plan. Before you close the interview, ask, is there anything else you want to ask? This question. Yes, Dhwani. Yes, Dhwani. Dhwani?
Sorry, I just wanted to interrupt there when you were discussing about having the family members in also.
Right.
What if the patient doesn't want their family member to be involved in a discussion about their treatment? Do we give that autonomy to the patient and say, yes, that's fine, or do we insist on family members or other caregivers also to be
We
interested?
do give the autonomy to the patients, but we'll inform the same to the family members. See, the patient has chosen so and so. Always the autonomy and beneficence part, patient has the autonomy to choose the decisions for himself if he is in a very capable position. For example, if he is not intellectual, there is no intellectual disability, there is no cognitive impairment, no such issues. There is full right, full autonomy for the patient, but we'll make sure that the family members also gets to know about his or her decisions. We cannot, the thing with the Indian context, okay, if it's a Western side, Western context, that situation is going to be different. You will have a more idea when you take up the communicating bad news, okay. Even when you're communicating bad news, we always, even if the patient wants to know, we take the consent from the caregiver. See, because what we usually see in Indian context is that, okay, we break the bad news directly to the patient, okay, and the patient has a breakdown and the patient cries and makes a cries, and suddenly the patient collapses, faints, or dies. The family members is going to burn the hospital, right? See, this is the Indian context. If it's the Western context, this is going to be entirely different. But when we come to the Indian context, we make sure that the family members also get to know about this. Even before communicating bad news, we take the consent of the family members and then communicate. And at times there are family members who would say, anyway, she is in a better position. We won't just let her know that she is in a stage 4 or the prognosis is poor and all. We won't say, we are not interested in saying. There are family members who are reluctant to break the bad news or communicate the bad news. So what we do is that we have multiple sessions with the family members, and if the patient is willing to hear the bad news, we let the family members see the patient has some idea of bad news, and the patient is wanting to know about the news. So we might be in a position to tell the to communicate the information to the patient. So we let the concerned person or the family members know, and then we'll disclose the information with the patient. That's a huge process that we do in communicating bad news. That's a 6-step process. We use spike protocol on it. When it comes to the decision making also, similarly, the patient do have autonomy, but we make sure that the family members also get to know about the decision. And we'll explain why it is important that we respect the patient's decision. Dhwani, is it okay?
Yes, thank you so much.
Thank
Thanks for explaining that.
Right. Before we close the interview, we make sure that yeah, in case you need to contact me or my team, you can call at this given number within this time frame, and all. Obviously, we'll have our own priorities, boundaries has to be set. And greet again, make eye contact, smile, nod your head, say goodbye, namaste, apushiri, whatever it is, and you can wind up the conversation or wind up the history taking part. So this is how you usually take the history taking part. And if you're seeing the patients in ward, it is going to be a little slight modifications here and there, because you already have rapport, you already have established your rapport, you already know the patient, right? So that is how that going to be. Any doubt in this area? Any other queries when it comes to communication, decision making, or anything else? See, there might be sometimes we had patients in our IP who had requested for a prayer, and we make it possible. We try to make it possible. It's there small wishes that accounts, right? So maybe we might inform the caregivers also. We never use the term. I think it might has that might have already been taken. We don't use the term bystanders. We use the term caregivers. So we inform the caregivers also, the concerned people also. So, they are like saying this way. So we might have to do this. So always we let the caregivers also know what the decision is, but always the patient's priority. Even there are patients who had asked for palliative sedation to us. The patient themselves had asked for palliative sedation. So we had to have conversation with the family members, convincing them why the palliative sedation, why the patient is saying so, and why it might be better for her and all. So we'll try to convince the family members, and then we'll go with the patient's decision. There was this patient who actually had asked, she was in severe pain, and she was in there was like very poor prognosis, and she was in her last few days, and she asked for palliative sedation herself. She herself asked for palliative sedation and all. So we had to like have a conversation with the family members, and then we made it possible. Any other queries from your clinical experiences or anything? Please use the chat box. Okay. So, what are some of the take home messages? Empathy as an experience depends on how we behave with our patients and their families. So, empathy is very important. They have to feel like we are there. We understand. We acknowledge what they are going through. Patients and family members remember how they were made to feel, how they felt. They are not going to remember what kind of medicines we gave, or obviously that is going to be a part, but more than that, how we made them feel, how comfortable we made them, the way we have approached them, this they are going to remember. That's what's mostly what they remember. Talk less and listen more, practice positive body language, and remember the verb of do's and don'ts. And with that, actually, we come to the end of our session. So actually, we had presentations, right? But I don't think we have received any presentations as such. So usually the last 15 minutes we use for presentations, case presentations and all. That is okay. I'm open to questions and queries. Yes, Shanmukha Priya.
Not a question. Thank you for a nice session, and thanks for the participants for a lot of insights and inputs. It's just add on from personal experience. Also don't, what about like there will be along with the patient in our context especially. So caregivers, and there will be somebody who knows another doctor, and there will be someone else who is from abroad. So there will be a lot of factors influence, especially in a case of treatment with a woman, especially a single parent or a separated woman. That happens. So a lot of factors. Some uncle will give some opinion. So this exhausts the palliative care physician as well as the counselor, because one day they will bring somebody, then the next day somebody else will come with some other ideas. So what I usually say, ask this in the first appointment or in the second appointment after talking with the patient, if the patient themselves are coming, and if I see different caregivers coming. So I asked, see, from our team, so these are the people, like I'll introduce the team where, say, will be communicating with you, and this will be the key person. It might be a nurse or a social worker or a psychologist. And you can, any medical related queries, you can contact me in this number at particular time. So who should I be talking with other than you, with discussing anything regarding your diagnosis or prognosis? Then your family, who will be the person other than you will be taking the decision or along with you. So this is what I usually practice. But even then, this overlaps will happen. Somebody else will come, and that do exhaust the palliative care team actually. Sometimes, especially towards end of life discussions, that happens.
Exactly. Thank you so much, Priya, for your inputs. This usually happens. There are at times, cases where, they won't care for the patient who is here for a very long time, and once they pass, they all the relatives are going to be at the hospital and saying, you didn't inform me. This is because of the care. You didn't care enough. The hospital was not good enough. At that point, we don't know from where all these relatives come up. They do come up. So these scenarios do happen, especially in a palliative settings. On and off, these things might come up. So make sure that you're from your side, you convey whatever is possible from your end. The treatment options that are there in your side, treatment options, what you are planning to do, explain your facilities. For example, Pal in India, we have a very limited facilities. We don't have ICU and all, so it's a palliative care, exclusively palliative care. We don't have any other specialization as such. So we inform before even admitting the patient to the caregivers as well as the patient that, so this is a palliative care. We don't have ICU, CUC, and so is this okay for you to admit the patient? So we take their consent also. And there are at times there might be issues between the children. The elder child will say that, the younger child will take care of the mother. The younger child will say that the elder mother is going to take care of the child. So there are going to be a lot of arguments that come up and all. So make sure that your part, you won't face any legal formalities or anything like that. So make sure that there is consent, the consent is signed, and you inform the concerned persons that the hospital authorities, the institutions won't fall into any issue or something like that. Documentation, exactly. Documentation is very important. Make sure that you take consent, written documentation, everything is done so that you are in a safer place. Right. Any other doubts, queries? If at all there is anything else, please put up the question up in the WhatsApp group. Okay. Or else I'll just wind up. If there is no other queries, I'll wind up for the day. Thank you so much for being interactive. For all those who have responded in the chat box, or all those who have used non-verbal communication today, and all those who have unmuted yourself and spoke to me. Thank you so much. Thank you and have a great day. Thank you.
Thank you, ma'am.
Thank you.
Thank you very much.
Thank you.
Thank you.